Welcome to the Research Works podcast, live from the European Academy of Childhood Disability Conference 2024 in Bruges, Belgium. Join us for interviews with keynote speakers, world-renowned researchers and clinicians, and behind-the-scenes stories from one of the great paediatric conferences in the world.
Dr Kate Langdon is here on the podcast right now from the Perth Children's Hospital and the Telethon Kids Institute. Kate, someone I know very well, but welcome to the podcast.
Thank you very much, Dana. It's really lovely to be here.
Always lovely to chat. I love that we're from the same city and then we have a chat in a room on the other side of the world to talk about your work. But this is what conferences do, right? It's often actually quite hard to connect when we're in our own city.
That's true. Yeah, we're too busy.
And today, it often is the case, but today we're talking about a really, really interesting paper that you'll be presenting at this conference. It's titled Hospitalizations Following Complex Hip Surgery in Children with Intellectual Disability. Super interesting, so important. Before we delve into some questions, can you I know it's really hard to do this in 60 seconds, Kate, but we'll give it a go. Can you summarise what this work actually entails?
I can. I hope. I think that people who are interested in intellectual disability as separate from cerebral palsy, although we know that there is good evidence for improvement in general health and quality of life when you address the hips and cerebral palsy, is there a problem in intellectual disability that we're not identifying and addressing because children with intellectual disability are not included in any of the surveillance programs? And we do know that children with intellectual disability move less. They have a lot of comorbidities, sensory impairments, and they do have, among their complications, musculoskeletal problems.
Yeah.
And the prevalence of intellectual disability is also increasing. So, and the risk of hospitalisation is 2 to 10 times the population rate, with an early death in severe intellectual disability. So we wondered whether the correction of hip deformity and better postural symmetry and improved comfort might reduce in the long-term seizures hospitalisation rates in general and also for lower respiratory tract infections. So we used link data from the Intellectual Disability Exploring Answers and the WA Register of Developmental Anomalies and linked it together with other data bases in Western Australia, retrospectively, but prospectively, for children all the way back to 1983 to December 2019 for children up to the age of 18 who'd had hip surgery by December 2014 and looked to see whether their hospitalisation rates what had happened basically. 12,290 children were identified with intellectual disability, of which about 2/3 had cerebral palsy.
Yeah.
And 154 of those children had hip surgery. And in the years that followed, the rates of all-cause hospitalisations dropped significantly by year 2, 3, 4 and 6. And similarly, epilepsy hospitalisations reduced, or the incidence ratio rate IIR decreased on year 2 and the trend was downwards following their surgery.
Interesting.
But interestingly, the lower respiratory tract hospitalisations generally trended up, but there was a delay before this happened up to about the 4th year post-surgery. So I think there's a concept that the children who had hip surgery seemed to have overall improved health.
Yep.
It didn't seem to make much of an impact on their respiratory health, however. And we don't know whether this reflects a bigger picture of the natural history of intellectual disability.
Yeah.
And to what extent this also would reflect the pattern that might be seen in a low or middle income country.
Sure.
Because we have access to people who can manage epilepsy and hospitals that can manage other comorbidities that might arise.
Yes.
But we do see that whatever's happening in their chests causing this later pattern of respiratory tract hospitalisation is not mitigated, not by their hip surgery at least.
Ooh, that's really interesting. And I think there's a lot to unpack there when it comes to this. There's so much to unpack. Thanks, Kate. First of all, with regards to the population, I suppose when we talk about intellectual disability, we never really seem to talk about it on its own.
No.
Really, do we? It's always like a comorbidity that we might talk about in relation to something else. So this study is very unique in the sense that you did really want to focus on intellectual disability. Did a lot of these children have other, like, did they have another diagnosis, or were there many standalone intellectual disability, or they're all related to cerebral palsy? Like, how does that pan out?
There's about 1/3 standalone. And
right.
all of the various conditions that are associated with intellectual disability may or may not be included.
Yeah.
But we went back and reanalyzed it to make sure that it wasn't just another, really actually just reflecting CP, but it was about 2/3 CP, 1/3 intellectual disability due to other causes. So I think it's also because the children with Rett syndrome, for example, because they have a known diagnosis, were not included on standard hip surveillance programs.
No, they're not,
And there was, like many conditions, life expectancy is long. So that you really do need to get your ducks lined up with managing hips. In the same way that you do with children with CP, following those guidelines and hip surveillance guidelines, because you don't want children in adulthood suffering with the pelvic obliquity, the asymmetry, pain, the sleeplessness and the evolving scoliosis that might happen if you have hip dislocation, migration and
That's right, because often in childhood it might be silent.
Yes.
But if we're not monitoring it, by the time it becomes such a big problem, it is a big problem.
And also when we're looking at the hip surgery, most of it was done after the year 2000. So I don't think that we're really looking at salvage surgery either.
Okay.
Thankfully.
Yeah.
There seems to be osteotomies and probably various derotation osteotomies or something similar.
Yes.
Sort of bony surgery that has a prophylactic or preventative task.
Yep.
And we're pretty across the difficulties of salvage surgery and the unsatisfactory outcomes. So we don't want to be offering a less good orthopaedic treatment to a small or to a segment. But the hard part is we have to still understand how we would go about offering surveillance to children with intellectual disability.
That's right.
Noting that there is a population increase, the incidence rate has another new learning for me, that the prevalence in WA of intellectual disability has been steadily climbing. It went up from 14 to 17% from 1999 to 2010 and then has jumped again more recently.
So many questions around that even, isn't there? Why is that the case? Are we better at assessing? Hopefully we'll be better. But what would the other reasons possibly be? And the interesting thing, I was thinking back to a conversation I had with Sue Stott in New Zealand, and she was talking a lot about hip surgery and the sort of shift in thinking that a lot of the times previously, particularly with cerebral palsy, was very passive, bracing, stretching, Botox doesn't seem to be really working because it's more about the active component. They're not as active, the muscles aren't pulling on the bones the way they should be. And I guess viewed that way, it makes sense for kids who have intellectual disability, even though without a diagnosis of cerebral palsy, they're just less active. Their muscles aren't working in the same functional way. The bones aren't developing quite the right way. I mean, that's the way I'm kind of thinking where that might fall into.
I think that's right, that level of activity and weight bearing is reduced, and for various other reasons, and also because of the similar sort of comorbidities involving the sensory impairments, vision and hearing.
Yes.
So that there's more kind of danger in the environment and there's opportunities to really roam around freely, and perhaps less the environment itself is changing over time.
Yeah, true.
It's more built up.
Yeah. Yeah.
While it's kind of technically safer,
Yeah.
is it safer?
Yeah, true question.
You need to be have your wits about you. Ambulating in Bruges, for example.
Absolutely. There's steps that appear out of
Steps
nowhere.
and bikes. And you need to have,
yes.
eyes 360 degrees around your head. So, and there's a cognitive component in being safe.
Yes. Yeah.
Ambulating.
Yep.
In a complex world.
Isn't that really interesting? And whilst mobility might be very possible from a murder perspective, there's all the other parameters we might put on top of that to keep someone safe.
Yeah.
Which would influence their mobility. So lots to think about there, as always, Kate, whenever I talk to you. So you did some complex analyses. When I look at your analyses, I go, wow, you really looked into a lot of things there. My question, don't worry, I'm not going to ask you too in-depth statistical questions because I feel like that's a little bit beyond my scope. But I'm interested with these kids that did have hip surgery. How did they end up having hip surgery if there was no surveillance program for children with intellectual disability?
How did they find their way?
Yeah, that's right.
Well, no one knows because it was done by data linkage. So they appear on the database in one place and then appear again in the database in another place, having had their surgery and intermittently being admitted for epilepsy or other reasons. So that process is unknown, how they got there.
Right. Almost feels a little bit lucky that they did to actually be detected at that time.
Well, I guess one of the things that was a little bit reassuring was that the age at surgery was fairly young.
Yeah.
That the mean age, I think, was 8 years of age. And although there were most children lived in major cities, there were a reasonable amount of children, nearly 30%, came from regional areas.
Yeah.
There was 11% of missing data as well. There were quite a lot of Indigenous children, a quarter of the children were Aboriginal, and they were in the hip surgery group. So I was a little bit reassured that they had found their way to someone who addressed it.
That's right.
Even with a sort of without a surveillance program.
Yeah.
So, and I don't think it was just the 2/3 who actually had cerebral palsy either. And even if they had cerebral palsy, given that this data goes back to 1982, well before surveillance started, somehow maybe the centralisation of services had helped a little bit. I would like to
very reassuring.
Yeah, I would like to know a little more about whether the children in the regional and remote areas had the same outcomes.
Yes,
but at least they got to have hip surgery.
Yeah, and
what was nice too is that the numbers who had not had surgery are about 25% in the regional and remote, and about 28% in the ones who did. So the numbers are fairly similar. Yeah. So I found that sort of reassuring that we do capture. There's not a huge divide.
Yes. And I suppose from there, like if you were to put in place a surveillance program, you might not be shifting the dial too much because we're really thinking about it, rather than starting a whole new surveillance program from scratch. There is something based there.
And maybe we just expand the one we've got and not be too kind of ridiculous and say, oh, no, they haven't got cerebral palsy even a CP-like condition.
Yes. Yep.
They go straight to the orthopaedic surgeon. So it's just, it's just such a good idea.
It is. Get an X-ray. Let's just have a look at that. It's very simple. We're very skilled at doing that now. Now let's jump quickly into the hospitalizations because that's very, very interesting because you base, to sum it into one line, you say complex hip surgeries can protect overall health but not respiratory health.
Yeah, I think
so related that to epilepsy, which is often very co-occurring, I suppose that's often on people's minds. Why do you think that
improves?
Yeah.
Well, I think that has something to do with perhaps a natural history of epilepsy itself.
Okay, true.
That there is an improvement over time.
Yeah.
But again, I don't know the data well enough about whether or not that is in all environments or only in, more in better resourced environments.
Okay.
And how dependent that is on the availability of anti-epileptic medication and the support of management. I do not know that relationship very well. And whether or not that reduction in epilepsy over time is a kind of whole body response to having had a gastrostomy if you need it, so that you can get your anti-epileptic drugs if you've got them.
Yes.
Because that data has been found in this similar data set earlier, or whether it's, it's some kind of central effect where over time there's just less activity. Perhaps children start to sleep better and they're in less pain perhaps.
Yeah.
So that's a really great question as to why their epilepsy may get better. But I guess we would hope that most of these children had their hip surgery before they became painful.
That's right.
They're not getting salvage surgery. So they may be sleeping better, they may be sitting better.
Yeah.
But let's hope it hasn't been because their pain was contributing to an increased rate of seizures. But
that's where my brain went, You're right, because as they get older, they've got their meds probably more sorted, the effect on sleep, it kind of, you do start to see it even out, between 6 and 8, they start to get on top of it a bit more.
Yes, I agree.
And then pain has a lot to do with it, sleep, irritability,
and maybe parents also get a little better at recognising what is and what isn't a seizure.
True.
And sort of some of them say, you know what, I do think this child is having seizures, and everyone's a bit more happy about, okay, maybe we do need medication.
Yes.
But there may be also a bit of a golden era prior to puberty when there seems to be another spike.
Yeah, true. And I guess when you're thinking about, you talk about here about the musculoskeletal alignment, there's such importance in that, isn't there? And it's not all about spasticity. It's not all about dystonia. It's often about inactivity that can lead to a lot of that. And that in itself has its impact on sleep, and it just keeps going. I guess to sum up here, what you think about in terms of your recommendations for clinicians, for those listening, most people would have a child with intellectual disability in their caseload for sure.
Yes.
What would your recommendations be for them as a step forward from here?
If prior to an inclusion of children with an intellectual disability being in a hip surveillance program, if you're aware that their level of activity is likely to be low and that most of their mobilisation is done in wheeled mobility, for example, I would get an X-ray of their hip and spine, and I would include their spine as well, so that you have an idea about whether, just so you can monitor that.
This is a baseline at that point,
yeah, and to really consider 24-hour postural care if that's needed.
Sure.
And also to be able to really optimise seating for that child as well.
The interesting thing that I didn't pick up earlier was, the relationship between intellectual disability and hypotonia.
Yes.
So, 24-hour position is very important here, isn't it, and the alignment. Kate, as always, lots of food for thought. Thank you very much for sharing that with us today.
Oh, thank you very much, Dana.
Always love it. Love our conversations. To all of our listeners, I hope that was really useful for you guys as well. Stay tuned for more episodes. We'll talk to you again really soon. Bye.